So I'm just going to discuss couple of cases. I promise I'll not be bringing any studies or any PDF screenshots. So I'll be just discussing couple of cases which I have managed and what I have learned and what questions still I have in my mind. So I feel we all know the etiology for these submacular hemorrhages primarily in our clinics are trauma or PCV or ruptured macroaneurysm. In West, the most common cause for these hemorrhages in my experience was mostly choroidal neovascular membranes, which are because most of these patients were already on some anticoagulants. Uh, why we actually need to start this treatment at a very early stage just to avoid this irreversible damage to the photoreceptors, and there have been multiple theories proposed as a cause of these photoreceptor damage, starting from the toxic destruction due to these ferritin or hemosiderin, or once the clot retraction happens, there could be some stripping of the photoreceptors, and this clot itself can behave like a diffusion barrier. So what are the options we have available right now, starting from the pars plana vitrectomy and aspirating this submacular hemorrhage, or just an intravitreal gas, or with or without combination of intravitreal TPA, or we just observe. Just a slide on TPA. What is TPA? Is a serine protease which actually works on a fibrin specific thrombolytic activity. It converts the plasminogen into the plasmin which liquefies the submacular blood. Before I start the cases, I would like to just mention the cost of this TPA is 26,000. So whenever we advise, we need to know what the patient is going to spend and what their expectations are going to be. So to start with, I had one case of a 33-year-old female who came to me in 12 hours after the trauma. They were really well-to-do. She got hurt in her eye, and because of which there was a sudden vision loss. She was absolutely fit without any systemic history. Her other eye was 20/20, and the eye which got hurt was counting finger close to face. The anterior segment was absolutely all right. This was the picture when she came to me 12 hours after the trauma, and as you can see, the submacular hemorrhage and the darkish looking blood in the center, but you can see a thin blood layer in the periphery. So I had a long discussion with her. I discussed multiple choices of the treatment, and this was the OCT which actually clearly shows you the submacular hemorrhage over here. Subretinal hemorrhage, I do not see any sub-RP component right now. Please keep looking at the sub-RP component because we really don't have any clear-cut management idea about this sub-RP hemorrhage. So I had a detailed discussion with her, and we ended up deciding that okay, they are well-to-do, they can afford 26,000 rupees, so might as well inject an intravitreal TPA. I was not very keen on doing a subretinal surgery because it was just a 12 hours post-trauma, so we injected intravitreal TPA with gas injection and prone positioning. So she came to me in 1 or 2 days, and this is the picture of 8th day picture where you can see the subretinal hemorrhage has actually moved aside, and you can see the choroidal rupture. The visual acuity has improved from counting finger close to 4 to 20/200. So, and this was the OCT picture where you can see the subretinal hemorrhage is almost gone, but little bit is still there along with this choroidal rupture, which is actually very close to the fovea. We just observed, and this was the picture at 2 months. She has improved to 20/40 from counting finger close to face. So she really thought it is a miracle because I had given a very, very bad prognosis, which is very, very important when you deal with these patients. So she was doing absolutely well. But I had question in my mind, was TPA required? I said, okay, they could afford, we did it. Fortunately or unfortunately, in few weeks time, I had one more patient of a 18-year-old boy who had an injury 2 days before following trauma with ball. And this was the picture. As you can see that there is a subretinal hemorrhage over here, and the fovea is actually involved. His vision was counting finger 1 meter, and this was the OCT picture where you can see the subretinal hemorrhage and the fovea is also elevated, and mind it, there is no sub-RB component still. So we decided, okay, we'll just inject C3F8, we'll not do anything, and he maintained the prone position, and in a week time, it was fantastic. He improved to 21/26. The OCT was looking really good, and we observed in a month time, he improved further to 20/60, and you can see the choroidal rupture over here very clearly. And this was the OCT. OCT shows some damage to the outer retinal structures, and this is a choroidal rupture which is clearly seen. So let's move to the third case, which was actually from Calcutta. She was a 43-year-old female. She had a sudden painless vision loss for last 1 month. She had seen almost 7 to 8 retina specialists. Most of them were my teachers. And she was with hand motions in the left eye. I saw the patient. Patient had a vitreous hemorrhage with a large subretinal hemorrhage, as you can see here. And I had a long discussion with her. I told her, you have seen all my teachers. I don't think we can do anything. But if you are ready, we'll take a chance. So these were the other photographs. The view is very hazy because of the vitreous hemorrhage. So this was the OCT picture, and if you really look carefully, you will be able to see that there is a large sub-RP hemorrhage along with this subretinal hemorrhage over here. And this is the hemorrhagic PED and the subretinal hemorrhage in the other quadrants of the macula. So we decided to take a chance of subretinal TPA with fluid gas exchange with under very, very poor visual prognosis. And we suspected PCV, so I decided to inject Avastin as well at the end of the surgery. This is the short surgical video. Hopefully it works because it has originated in MacBook. All right. So the vitreous hemorrhage you can see, and I'm inducing the PVD, and the vitrectomy in these cases is very weird experience because the vitreous is pretty sticky. It is a breakthrough hemorrhage, and the PVD induction is also little different experience. This is the 38 gauge needle which I am using, and I tried doing a subretinal injection over there, which I actually failed. Then my suggestion is that you go ahead and start somewhere in one of the corner areas where the retina is elevated, and you can see that I'm injecting subretinal TPA and the bleb is forming, and our goal is to bring this bleb up to the disc. So we actually liquefy the blood in the subretinal space, and you can see the bleb is really nice, and the blood is actually started looking little different color, and it is getting liquefied. And after making a bleb, I just did a fluid air gas exchange and injected Avastin injection. So let's see what happens at 1 week time. We see the visual acuity has improved, but it's not magic because vitreous hemorrhage is cleared. But yes, the subretinal hemorrhage has also moved slightly, and that is the gas level we can see. And this is the OCT picture which actually shows that the subretinal hemorrhage has reduced, and still the sub-RP hemorrhage, the hemorrhagic PD is still there, though it has decreased compared to the baseline, but it has actually reduced significantly. So we just observed, and the patient was actually miraculously doing really well. She improved to 20/50, and this is the subretinal heme which is actually resolving. The hemorrhage has moved to the other quadrants, and this is the OCT picture which is actually showing you the hemorrhagic PED has significantly reduced. If you really see, the height of the hemorrhagic PED has significantly reduced. The subretinal hemorrhages has almost disappeared, and at 1 month her visual acuity was 20/50, and she's actually in regular follow-up with me. After a year we did a cataract surgery, and she is doing 20/40, and she's really happy. So by looking at these cases, I thought, okay, what should be our approach to these cases, and what are the questions, and what are the things we really need to consider when we are dealing with such situations. So these are a couple of points which I have put. I would really appreciate inputs from all of you and try to improve this slide. That what are the things we need to consider is the duration of the subretinal hemorrhage, and how do we actually know the duration? Do we actually believe the patient, or we look at the color of the hemorrhage? So I always like to look at the color of the hemorrhage and try to understand how old it could be, and what is the cause of subretinal hemorrhage, which is a very important thing, and what are the various surgical approaches we should look at these cases. What is the dose of intravitreal or subretinal TPA, and the level of hemorrhage, which is still controversial for us. So let's look at the duration of the hemorrhage. What I prefer, if the patient is coming to me within 2 weeks, I actually try to give them only gas injection. No need of spending 26,000 rupees. Let's try this. And if the hemorrhage is looking slightly old and it is more than 2 weeks or less than 1 week, the clot is not very well formed, we can still try intravitreal TPA, because personally I still have doubts that whether only intravitreal TPA works. And if the hemorrhage is pretty old and you are seeing a clot very well, and you can still give a chance by doing a subretinal TPA. But if you see a really thick clots which are actually looking pretty organized, these cases are not going to do well because the photoreceptor damage has already set in. So what is the cause of subretinal hemorrhage? We all know the trauma cases do really well because they were absolutely all right just before the trauma, depending upon the choroidal rupture where it is causing through. So this helps in prognosticating the cases. In terms of the PCV or AMD, as we all know that depending upon the subfoveal scarring, what is the status of the disease, primary pathology, it depends what is the prognosis. And the RAM cases or coagulopathies, in my hands, they have really done well. What are the surgical approaches? If you really look at the typical surgical approach, you can just make a large retinotomy, remove the clot, but we all know this is not going to help much because it is going to cause much more problem in the posterior fold. So the preferred approach is subretinal TPA, then fluid air exchange. But one of the interesting technique which was proposed from Dr. David Cho from Canada was you inject the subretinal TPA into the subretinal space, make an inferior retinotomy, just do the fluid air exchange and leave it. This inferior retinotomy is actually going to help you to remove this liquefied blood inferiorly and the patient do well. They have reported a very good cases. I have tried in one case but it did not do so well. And we are really afraid that whether it will cause a retinal detachment or not, because we all have burnt our hands with gas only. And one of the cases, interesting cases, which Dr. Manish Nagpal had shown, I think a year or two before, when he experienced a large subretinal hemorrhage, he did a 180 retinectomy and removed the clot, but the visual prognosis again is pretty dismal. So what is the dose of TPA? We really don't have a very clear idea. What experience we have is from the couple of rabbit studies. We really don't know what is the exact dose. So intravitreal TPA, as I said, I really have concern about the passage, though the rabbit studies have shown that it has passed the retinal space, but how good it works, it all depends how old the hemorrhage is. What about the subretinal hemorrhage? The usual dose which is recommended is around 25 to 50 microgram, but in my cases I definitely crossed more than 100 microgram because we are making a large bleb. So we really don't know what is toxic. If the patient is doing well, we are good. Otherwise, we blame the subretinal hemorrhage that it has caused toxicity. So the level of hemorrhage it is pretty interesting. Just the same case which I am showing, that the subretinal hemorrhage, the top image is the baseline, the last image is on the follow-up. Patient is doing really well. This is the second case where I have shown that the sub-RP, this is the third case which I have shown the sub-RP hemorrhage has actually resolved. Because in my traditional teaching, I thought, okay, whenever there is a subretinal hemorrhage, don't do anything, just leave it like that. To the best of my surprise, I had this case like just 2 weeks before who actually came with after trauma, and you can see the majority of the hemorrhage is sub-RP hemorrhage. Because it was a fresh case, so what I did was I just injected gas and I said, okay, let's see after a week time. And the hemorrhage is actually, the subretinal component has actually moved to one side, but as you can see that the sub-RP hemorrhage is still persisting. So we really don't know whether the gas only works on sub-RP hemorrhage or not, I don't know. But after this OCT, I have taken this patient up for the subretinal TPA, and I'm still waiting for the for the results how this subretinal TPA actually works or not for the sub-RP hemorrhage. So for me, the unanswered questions are, we really don't know the role of intravitreal TPA as an adjunct to gas, whether it is worth making your patient to spend that much or not. And what is the minimal individual toxic dose? We really don't know, because we are playing with the subretinal hemorrhage, how much toxicity the subretinal hemorrhage has caused, and we really don't know how to handle the sub-RP hemorrhage. So at least from my presentation, I would say the take clinic message is, as soon as you see the patient, go ahead and start the treatment, whatever best option you have available, and depending upon the etiology, extent and the duration of the insult. And the combination treatment, I believe they'd really do well. The close monitoring and treatment of underlying cause is also important, because you have an active AMD, PCV, you just have done this subretinal surgery, but you still have to monitor them for the active disease and treat them with anti-VEGF injections or the best possible. Thank you very much for your attention.